Now we come to renal pharmacology. In the course of understanding renal physiology, we've already laid the groundwork to understand the vast majority of renal-related drugs. Therefore, this section should not require too much memorization. Let's talk now about the diuretics site of action. As we go forward with diuretics in this section, you can use this page as a reference to remember where in the nephron each drug acts and how that can be used to predict its effects. The main thing that I want to highlight in this diagram is that carbonic anhydrase inhibitors, like acetazolamide, acting on the proximal convoluted tubule, have relatively minor effects because whatever is not reabsorbed in the proximal tubule can be reabsorbed downstream in the rest of the tubule. Now, loop diuretics and thiazides have stronger effects because there is not much of a mechanism to reabsorb the ions after the loop of Henle and distal convoluted tubules. So why do potassium-sparing diuretics and ADH antagonists, why do these have relatively minor effects? The answer is because most of the ions and water have already been reabsorbed by the time the filtrate reaches the collecting duct and the tubules. Also keep in mind that all diuretics except the potassium-sparing and antidiuretic hormone antagonists will increase the excretion of potassium, except the ADH antagonists and the potassium-sparing diuretics. This is because all of the other diuretics increase the delivery of sodium to the collecting tubules, which then gets reabsorbed, and that creates a more negative lumen potential in the collecting tubules, and this negative potential then causes increased excretion of potassium as well as hydrogen ions. So we'll keep our diagram off to the side here so we can look at it when we need to as a reference. Now let's start off with the first diuretic, mannitol. This is a sugar that is freely filtered. It's freely filtered by the glomerulus, but it's not reabsorbed. The excess solute in the lumen of the tubules then causes an osmotic diuresis because water stays in the tubules. Clinically, it's used for drug overdose and increase intracranial or intraocular pressure. For drug overdose, the drugs that it's used for are hydrophilic drugs, because mannitol can increase the diuresis of water, and that will take the hydrophilic drugs with it. Toxicity of mannitol includes pulmonary edema, congestive heart failure, dehydration, and it's contraindicated in anuria when patients can't produce urine. So the reason it's causing pulmonary edema and CHF is that too much mannitol can cause water to come out of cells and into the interstitial space. And if patients are diuresed too much with mannitol, they can become dehydrated. And what happens if patients can't produce urine? They won't be able to excrete the mannitol that is given to them, and this will also pull water out of cells and into the interstitium. One last thing to mention. On your exam, look out for mannitol being given during neurosurgical procedures to reduce intracranial pressure. The next drug is acetazolamide, which we mentioned is a carbonic anhydrase inhibitor. By inhibiting carbonic anhydrase, bicarbonate is not reabsorbed because it's not converted into what? CO2. And this causes the bicarbonate to be lost with sodium in the urine. Now, clinical uses for acetazolamide include glaucoma, because it reduces aqueous humor pressure. And it's also used for urine alkalinization to prevent certain kidney stones. Do you remember which type? Uric acid stones and cystine kidney stones, which, remember, both of these stones precipitate at decreased pH. It's also used for metabolic alkalosis because it's removing bicarbonate from the body. In altitude sickness, patients will have a respiratory alkalosis, and so excreting bicarbonate can help reduce that alkalosis. And pseudotumor cerebri, which is a condition of increased intracranial pressure, excreting water and bicarb can help reduce that intracranial pressure. The main toxicities for acetazolamide is hyperchloremic metabolic acidosis due to the loss of bicarbonate in the urine. It can also cause paresthesias, ammonia toxicity, and sulfa allergy because it's a sulfa drug. Okay, flash quiz. In what two conditions is mannitol contraindicated? Answer is anuric renal failure and congestive heart failure. Remember that if mannitol builds up, it can pull water out of cells. So water will come out of cells into the interstitial space. And this is dangerous because that interstitial edema can lead to pulmonary edema, and it's already problematic with patients with CHF because they already have fluid in their lungs. The next drug, furosemide, is in the class of loop diuretics and is very important in clinical medicine. As we've already talked about, it's a very powerful diuretic that works by blocking the sodium-potassium 2-chloride transporter, leading to loss of sodium chloride and potassium chloride in the urine. This reduces the hypertonicity of the medulla. So here's the medulla, reduced tonicity. So what will this do to the ability of the kidney to concentrate the urine? With reduced tonicity in the medulla, the kidney will not be able to concentrate urine using the countercurrent exchange multiplier, and therefore more dilute urine will be lost and more fluid will be lost in the urine. Furosemide also stimulates prostaglandin E release, and this causes a vasodilatory effect on the afferent arteriole. So what will that do to the GFR? It will increase the GFR, leading to more filtrate production. Also remember that loops lose calcium, and loop diuretics will increase the excretion of calcium. Furosemide is very important clinically, and it's used to eliminate fluids in acute edematous states such as CHF and cirrhosis. And it's also a common drug used to treat hypertension and hypercalcemia. However, it can have some adverse effects. The way to remember them is with the mnemonic ODANG: ototoxicity, hypokalemia, dehydration, allergy, because it's a sulfa drug, nephritis, which is interstitial nephritis, and gout due to hyperuricemia. The next drug is ethacrynic acid. It works in a manner similar to furosemide, So what protein is it blocking? The NAK2Cl cotransporter. And because it is similar in mechanism, it also has some of the same toxicities. Now, clinical use is that it's used for diuresing patients with sulfa allergies, and that's because this is not a sulfa drug. So it's preferred in patients that have sulfa allergies, and this is a commonly tested question on the exam. As we said, the toxicities are similar to furosemide, and if a patient presents with CHF and is given furosemide and develops an allergic reaction, the next time they have a CHF flare, you won't give them furosemide, and ethacrynic acid will be your drug of choice. That's the main thing to remember about this drug. Hydrochlorothiazide is the prototype of the thiazide class of diuretics. It works by inhibiting the sodium chloride cotransporter where? In the distal convoluted tubule. And this leads to loss of sodium chloride and water in the filtrate. And because this is not a potassium-sparing diuretic, it's also going to increase the excretion of potassium. Now, the distal tubule is important for diluting filtrate. So inhibiting the sodium chloride cotransporter reduces the ability of the nephron to dilute the urine. Therefore, more ions get excreted, sodium chloride and potassium, as well as hydrogen ions. Hydrochlorothiazides also increase calcium reabsorption. And this is by making the lumen potential more positive, since sodium chloride is not reabsorbed in the distal tubule, and that drives calcium reabsorption. Clinical uses of hydrochlorothiazide include hypertension, CHF, idiopathic hypercalciuria, and osteoporosis due to reduced calcium excretion. So thiazides will increase calcium reabsorption, and that's why it helps with osteoporosis. Patients with nephrogenic diabetes insipidus are also given thiazides, and this seems a little contradictory because patients with nephrogenic diabetes insipidus are already urinating a lot. Why would we want to give them a diuretic? And the reason is that thiazides will slightly dehydrate them, and this will lead to a decrease in plasma volume and GFR. And ultimately, this is going to lead to increased proximal reabsorption of sodium and water. All this helps the patient to maintain a low but somewhat normal plasma volume and not have to urinate all the time. Toxicities for hydrochlorothiazide can be remembered with the mnemonic hypergluc. Hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. And last of all, remember that this is a sulfa drug, so patients can have sulfa allergies to hydrochlorothiazide. Alright, let's try a flash quiz. Blank, furosemide or hydrochlorothiazide increases calcium excretion, whereas blank, furosemide or hydrochlorothiazide decreases calcium excretion. The answer is furosemide increases calcium excretion, and thiazide, hydrochlorothiazide, decreases calcium excretion. Remember that loops lose calcium. And I don't remember a great mnemonic for thiazides, but thiazides save calcium. Loops lose calcium because they make the lumen potential more negative. And thiazides save calcium because they make the lumen potential more positive. So a more negative lumen potential will keep calcium in the filtrate and cause it to be excreted, whereas a more positive lumen potential will increase the paracellular reabsorption of calcium and cause less of it to be lost in the urine.